evening, friends. Welcome to a brand new session of ACNS webinars for the month of February. Today, we are discussing two most intriguing diseases involving the nervous system, the hydrocaphalus and peripheral nerve surgery. The treatment of hydrocaphalus has evolved over a long period of time, from the ancient obsolete procedures like carotid artery ligation and trephination to the most modern neuroendoscopic interventions. The management of hydrocaphalus has progressed in leaps and bounds. However, like in any other neurological diseases, early detection and intervention is the key to have a long-standing cure. To tell us more about the advances in the management of pediatric hydrocaphalus, we have with us one of the most respected faculties in the field of pediatric neurosurgery, Professor Vanti Siu from Singapore. Professor Siu is the Senior Consultant Department of Neurosurgery at the National Neuroscience Institute, Singapore, and formerly Head of Department of Neurosurgery. He is also a Senior Consultant Neurosurgeon at the KK Women's and Children Hospital, Singapore, and was formerly Head of the Neurosurgery Services at KKH. Professor Siu is the President-elect of the ACN Neurosurgery Society and Secretary of the Asia-Australia Society of Neurological Surgeons. Professor Siu is involved in the postgraduate training of neurosurgeons at the NNI and is a member of the Residency Advisory Committee for Neurosurgery, Singapore, and a member of JCST Exit Examination Committee for Neurosurgery. He is an adjunct associate professor with Duke NUS Medical School. He was the past chair of the Education Committee for the ISPN and was actively involved in its educational program. He is also on the teaching faculties of the Pediatric Neurosurgery course in Asia, Europe, Latin America, and Africa. We are extremely grateful to him to have accepted our invitation to be a speaker at our webinars. The second speaker for today is one of the masters of peripheral nerve surgery, Professor Lucas Raslic. Professor Raslic is a consultant neurosurgeon, professor at Faculty of Medicine, University of Belgrade, and head of Department of Peripheral Nerve Surgery, Functional Neurosurgery, and Pain Management Surgery. He is also the head of the Clinic for Neurosurgery Clinical Center of Serbia. The main clinical and scientific area of interest is peripheral nerve surgery. He has held several academic positions in neurosurgery. To name a few, he was the president of the Serbian Neurosurgical Society, President of the Southeast Europe Neurosurgical Society, ENS 22 Congress President, Chairman of the WFNS Committee for Peripheral Nerve Surgery, Brachial Plexus Surgery, and Chairman of the ENS section of Peripheral Nerve Surgery. Professor Raslic has published more than 450 scientific papers in international and national in index journals and chapters in scientific books. He was the faculty at more than 100 international courses and trainings, invited speaker at more than 100 national and international congresses, meetings, and symposia. We are extremely fortunate today to have him with us today as a speaker to our webinars. The chair for today is one of the most respected faculties from Saudi Arabia, Professor Ahmad Umar. Professor Umar is the professor and head of Department of Neurosurgery at the KFHU Dammam, KSA. He is a vastly experienced neurosurgeon who has conducted more than 6,000 surgeries. His special interest is in pediatric neurosurgery. He is a noted author who has written one of the most famous books in neurosurgery titled The Hydrocaphalus, What We Know and What We Still Don't Know. He is on the editorial boards of several international reputed neurosurgery journals. He is a recipient of several awards and honors from Saudi government for his outstanding contribution towards neurosurgery. He is currently the co-chair of the WFNS Ethics Committee. We are extremely grateful to him to have accepted this invitation to chair this webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I hereby sincerely welcome today's speakers, Professor Vanti Siu and Professor Lucas Raslic, and the Chair, Professor Ahmad Ahmad, to this online platform of ACNS webinars. Dr. Liu Bun Singh from Malaysia is my co-host for today. And with that introduction, may I please hand over the platform to Professor Ahmad.
Thank you very much, Raja. Again, you are doing an excellent and outstanding organizations. Well, I am very pleased and honored to share this meeting with two of my very dear colleagues and respected colleagues. We'll start with Dr. Vanti Siu. He's a professor of neurosurgery. He is one of not only Asian leader in neurosurgery, but he is international or global leader of pediatric neurosurgery. His contributions in the field of neurosurgery is great. But I know him for many years, and he's an outstanding person with a vision and wisdom and very friendly. We enjoyed very friendly relationship. So it's a pleasure to be with you, and it is now the time to ask you to please to tell us about this important problem, hydrocephalus, or hydrocephalus. And after the presentation, I think it will be a lot of discussion, and then we may have time to discuss many issues and answer several questions. Please, Professor Vanti Siu.
Thank you very much, Ahmed. I am a bit shy to hear all the things that you say, but thank you so much for that. Okay, let me share my screen. So I was given the topic of pediatric hydrocephalus to talk on, and I mean, I think basically I look at hydrocephalus from a practitioner point of view more than the research part. So here we go. So I think the first thing is, what is hydrocephalus? Of course, we know hydro is water, cephalus is head, so water in the head. And actually, this is the one of the classic, how do you say, terms that is used by Harold Rickett, that hydrocephalus is an active distension of the ventricular system of the brain resulting from inadequate passage of CSF from its point of production within the cerebral ventricles to its point of absorption into the systemic circulation. And this is what is actually accepted, but really there's a problem from a clinical point of view. I mean, from us, we view this as a pathological condition because if we don't do anything, the child is going to get worse. Of course, the ventricles are usually enlarged. I think what we're actually treating is the associated intracranial hypertension. And as mentioned, it arises from imbalance of CSF production relative to CSF adoption. And I think, we know the bulk theory of CSF low, CSF. You can either use this diagram or the diagram that's put up by Rickett, where CSF is formed by the correct plexus in the lateral ventricles, and also in the correct plexus, the third and fourth. And the CSF that's produced goes through the foramen Monroe into the third ventricle, goes to the aqueduct of Sylvius into the fourth, and then from there it goes to the spinal subarachnoid space, and it goes over the cortical surface of the brain into the absorbed by the arachnoid granulations. So, and then from there it goes into the venous system, into the heart, and it pumps back again, right? So this is really what we are looking at. Of course, with new theories of, CSF absorption, for instance, we now know that there are lymphatics in the brain, that actually the nerve root sleeves and olfactory bulbs may also absorb CSF, and there is ependymal parenchymal capillaries that result in the flow of CSF. So it's not just the bacteria itself, there are new things that we may need to consider as well. And of course, classification there's lots of classification, but I think the most common for us is really based on etiology, is congenital versus acquired, obstructive, non-communicating versus communicating. And this is important because it tells us what we can do in terms of treatment. I think the rest in terms of whether it's acute, subacute, occult, and those, and even normal high pressure, those don't apply so much to the pediatric age group. Then you look at the again the classification. So in congenital or developmental hydrocephalus, you have either congenital aqueductal stenosis. It can be seen in neurotube defects such as the myelomeningeal ciliary malformation, of course, posterior fossa malformations, developmental cysts, and congenital foramen atresia. Whereas in the acquired, it can be inflammatory from hemorrhage or infection, from the presence of neoplasms or tumors in the brain can cause hydrocephalus. Right, correct plexus tumors secrete CSF and cause hydrocephalus. Vascular formations like vein or Galen malformation can also cause blockage and result in hydrocephalus, and you can also get disordered venous malfunction causing hydrocephalus. Okay, so these are some of the things that see, and what these do, these congenital causes are, they either cause some form of obstruction or mass effect, right? And so we can see that in, for instance, the congenital aqueductal stenosis. You can see it here. There's a aqueductal stenosis. It's associated with the L1 or crash syndrome, and is X-linked due to mutation of the L1 CAM gene. You can also get various types of aqueductal stenosis in the middle, more to the back, right? Or even in front of the whole thing is blocked up. Right? Then, of course, you have other malformations causing hydrocephalus. So the Walker malformation, a quadrigeminal arachnoid cyst, and even multiple suture synostosis can cause hydrocephalus. Then you can get a unilateral hydrocephalus because of obstruction of the foramen Monroe. And of course, you can also get obstruction by, for example, a correct plexus cyst that forms and then blocks up both um, foramen Monroe. In the acquired side, of course, you have actually a lot of them maybe due to scar tissue or obstruction. And then, of course, then the treatment is again, as listed here. Really, what you see, for instance, here is post-hemorrhagic hydrocephalus in a neonate with a intraventricular hemorrhage. You can get presence of brain abscesses then extending into the ventricles, causing hydrocephalus. And of course, in common in parts of this world here, TB meningitis causing hydrocephalus. right? Then of course you have the tumor. So like for instance, here is a huge big desmoplastic infantile astrocytoma causing hydrocephalus. You have a craniopharyngioma, in this case a 61 blocking up the foramen Monroe causing hydrocephalus, and of course a choroid plexus papilloma causing hydrocephalus. And then pioneer tumors blocking up the aqueduct, posterior fossa tumors, astrocytoma or medulloblastoma causing hydrocephalus. And of course, as mentioned, communicating and obstructive hydrocephalus is something that, we should try to understand. And historically, of course, the use of air encephalography to actually study hydrocephalus. Of course, now we use MRI. And you can see the difference here. This is a communicating hydrocephalus. You can see that the aqueduct is not blocked. Even the fourth ventricle outlets are not blocked. Right? So this is really communicating hydrocephalus. Whereas this one, although the fourth ventricle is enlarged, you can find that actually the foramen Majondi actually is blocked up, so it's causing hydrocephalus. And even on the axial cards, you can see that the foramen Luschka on both sides are blocked up. So this is really fourth ventricular outlet obstruction causing obstructive hydrocephalus. And so you can see the obstruction can occur anywhere along the CSF flow area, right? I think more important is that if obstruction is due to tumor, of course, you remove the tumor or the obstruction, and the obstruction is distal to the middle third and beyond, then you want to consider ETB. Otherwise, you can consider just shunting. And then, of course, when you look at scans, how do you tell whether there's hydrocephalus or not? So there are enlargement of third, anterior posterior processes, dilatation of temporal horn, narrowing of the mammillary pontine distance, angular uh, ventricular angle narrowing, widening of frontal horn radius, periventricular interstitial edema, effacement of the cortical saw site. So for instance, you look at here, dilation of the lateral and third ventricles here. Right? After treatment, you can see third ventricle is much smaller. Of course, in this case, this is a case of aqueductal stenosis. And of course, you can get dilatation of the chiasmatic and infundular recesses, again, as a sign of hydrocephalus, dilatation of the temporal horns, and of course, the mammillopontine distance, there's no hydrocephalus, and this distance is shortened when there's hydrocephalus. And of course, then we also know about the ventricular index, which is the ratio of the frontal horn over the internal diameter, or you can also look at Evans ratio, which is the uh, length of the frontal horn over the maximal interparietal diameter. And the ratio, whether it's more than 50 or more than 30 in this case, indicates that there's hydrocephalus. Right? And of course, the other things that we see, large ventricles, and we see periventricular lucency, and these are characteristic of raised intracranial pressure causing hydrocephalus. Of course, there are differentials. Right? Dilated ventricle does not always mean hydrocephalus. Right? It could be due to brain degeneration, encephaloplasia, or you developmental anomalies with agenesis of the corpus callosum that gives you a picture that like there is hydrocephalus. What are the signs and symptoms? I think we all, as clinicians, are very well aware, right? Because you've got raised intracranial pressure, you get papilledema, headache, nausea, vomiting, gait changes, upward gaze, abducent palsy, and then slowly enlarging ventricle may initially be asymptomatic, but as the pressure goes up, the patient becomes asymptomatic. Like those are what you see in older children and adults, but in young children, because many of them, the suture has not completely fused, so one of the things that you get is increase in the um, head circumference, right? And the cranium enlarges at a rate faster than the facial growth. Their fontanelles are full, bulging. There's enlargement, engorgement of scalp veins. There's a cracked pot sound, McEwen sign. Of course, sometimes they have Paranoid syndrome, and you see the setting sun sign, and then splaying of the cranial sutures. Right? So these are signs that you see in young children. Now, what about treatment? I think that's probably the most important thing, right? So, as I mentioned, if you can, you remove the cause of the hydrocephalus. So, removing the tumor will actually lead to the obstructing the flow. Right? Of course, then there are the CSF diversion techniques. We have the shunts, and then neuroendoscopy. Right? So, there's a whole list of shunts, but the most common one usually is the ventricular peritoneal shunt, occasionally the ventricular atrial shunt. Right? There are some in communicating hydrocephalus. There are some practitioners that would do lumboperingeal shunt. Then endoscopy is of course a very important part. That ventriculostomy, ETV, but CPC. Of course, you can also do septostomy or fenestration of membranes, depending on what the actual condition is. I think it's very clear that prior to the availability of neuroendoscopy and ATV, right, and this is around 1990, the main treatment really was shunts and nothing else. But of course, the presence of ETV gives us an additional choice of treatment. Now, shunts, okay, you always hear people say shunts are evil, avoid shunts. But realistically, shunts are a very important part of the armamentarium for neurosurgery for the treatment of hydrocephalus. And in many cases, they may be the only available treatment for many types of hydrocephalus. And one thing you can note is that shunt survival rates in children have improved over the years. And this is because shunt technology improves, and it's more to do with the catheters, antibody coated catheters, than actually the valves themselves. Right? But the most important thing is good surgical technique for shunt insertion. Right? These are important to ensure long-term survival of shunts. In a way, you can say that the neurosurgeon is the final manufacturer of the shunt. So questions like, you see cases like this, do you shunt or do you not shunt? I think in many places, the classic teaching was you see big ventricles, you shunt. But as I mentioned earlier, the differential, this is actually just ventriculomegaly, there's no raising cranial pressure. In this case, even though the ventricles are a little bit smaller, actually they are under high pressure, and these are the ones that need to be shunt. So it does not mean that big ventricles equal to shunts, right? Right. So big ventricles, ventriculomegaly is not equal to hydrocephalus, right? I think this is something that we need to be aware of, okay? And so that case here and this one, right? This is a case where there's big ventricles, but big subdural spaces, right? Heads are big. There may be mild developmental delay. This is actually benign microcranial infancy. Most of these children, the head stays big, but it's essentially these subdural conditions disappear, and they actually do usually very well, although they may be a bit delayed mentally. Other examples, right? People use the term external hydrocephalus, subdural hygromas, tissue loss, atrophy. So like this is a bronchiectasis. In this particular case, there's no hydrocephalus, right? Post non-accidental injury, because this is actually ex vacuo. And in the brain or myelomeningocele, many of them may have hydrocephalus. So you may have to shunt, right? So then the most important is try to avoid shunt complications. And shunt complications can arise from mechanical failure related to improper functional device. Also, although this is usually not a big issue, the valves are usually very resistant. You can get infection, right, related to implanted foreign material. You can have a functional failure, right, because of inadequate flow of a functioning shunt. So all these things can lead to shunt infection, blockage, migration, and fracture. So there are, when you look at shunt complications, they are early and late, right? Early is usually in the first year or maybe second year, and late usually more than shunt infection. I'll mention some of the cases of late shunt failure after this, right? What are the early complications, right? Usually examples are shunt-related infections, commonly caused by skin bacterial inoculation in the wound or implant. You can see here there's actually the CSF occurring outside of the thing following the shunt. So obviously there's some obstruction, right? Or maybe infection. These are usually related to poorly placed catheters or ventricular catheters or distal catheters. And less frequent complications in shunt extrusion, right, into the visceral organs and outside and so forth. And then these connections. And again, most of these complications, the early complications, are related to technical and performance issues. So really, the surgeon's role is a very important thing. As a surgeon, we control at least two aspects of shunt surgery that are potentially modifiable. One, of course, is the surgical technique, right? And this is focused on expeditiously placing the proximal and distal ends of the shunt in their respective optimal locations while minimizing the risk of infection, right? The other one is the using new technology. So to avoid early shunt failure, okay, obviously, as mentioned, shunt placement position, shunt tip placement, because the most common part of shunt obstruction is actually in the tip in the ventricular. You can consider using navigation, the endoscope, ultrasonic guidance. Obviously, your surgical technique should be good. And then again, shunt technology, right? So what about shunt tip position? Right? Where do you place them? Well, most of the time, the idea is to avoid the correct plexus. So you can come from the occipital horn and have the tip into the frontal horn in front of the foramen majeure where there are no correct plexus. you can actually do a caudal incision, so a burr hole, and then you have the tip in the frontal region. Or you can actually do an occipital burr hole with the tip in the occipital horn where there are no choroid plexus. So these are some of the positions that you can use, right? Now, normally, personally, I don't actually like to use the occipital burr hole to the frontal horn because, as you can see, sometimes you actually don't really get into the front horn properly, right? Although you can see you have to actually tube transverse actually part of the basal ganglia to get into the frontal horn. And then the other thing is that when you do this type of shunt placement, tip placement in small children, as a child grows, the catheter will pull back, and when the child is about 5 or 6 years old, the tip of the catheter is actually in the body of the lateral ventricle, just over the choroid plexus. So I prefer to actually use a proximal shunt tip placement into the frontal horn. Okay. And so, because long-term patency of ventricular catheter depends on accurate placement of the whole bearing segment of the catheter into the ventricle, away from injured ependyma and the choroid plexus. And of course, now we have image guidance to help you, but if you don't have, actually look for this article by Pang. They actually have a very nice description of how you can actually place the coronal ventricular catheter accurately, right, with freehand. Now, in terms of reducing shunt infection, obviously, a very important thing is to have a standard shunt surgery protocol with checklist. Do the same thing all the time, and after that, everybody in the team becomes good at it. If possible, use the same standard shunt. And for many of our children, actually, I just use um, a simple Medtronic valve, right? Flat valve because it's small, right? The most important thing is you need to know your equipment, how to do it, what to do. And then, of course, there are special considerations, use of intraventricular uh, and systemic antibiotics, use of antibiotic-coated shunts, right? Determining when to shunt after EVD insertion, and then knowing when to time reshunting after an infection, because all this can affect your subsequent shunts. Now, antibiotic impregnated antiseptic coated shunts useful. There are two main types. These are the clindamycin coated, right? So both the Bacterial and the Medtronic, or Silverline silver coated shunts. Now, we are very lucky that just the end of 2019, this paper came out in the Lancet by Conor Bellucci and his team, people in the UK, looking at antibiotic silver versus standard peritoneal shunts, the basics trial. And basically, it's a multi-center, single-blind randomized trial looking at the use of either antibiotic impregnated, right, in rifampicin, clindamycin, or silver impregnated shunts compared with standard shunts at reducing infection. Now, interestingly, shunt revision of infection was much lower in the antibiotic shunt group, even though the standard and actually the silver group are the same. So basically, there is definitely a reduction in the shunt infection when you use the antibiotic coated, right? And they look at adverse events. Again, the adverse events are about the same or maybe a little bit more in the silver group. And the shunt failure for all causes actually 25% over 2 years. So they actually had a 75 success rate, which is much, much better than what we know in the past. And in the UK, the savings of avoiding a infection is actually a lot of money, 136,000 pounds, right? And so basically they conclude that antibiotic shunts reduce the risk of infection, are substantially cost effective, and thus should be the first choice for patients with hydrocephalus undergoing insertion of their first BP shunt. And these are some of the graphs. You can see that initially they all look the same, but of course in the pediatric group it's always less, but you can look at the success rate. It's still better than what you see in the old group, and I'll mention this as we go along, right? And basically the idea is that current shunt failure rates are much, much better than the historical ones, right? Now, late failure, I say usually is the calcinosis of shunt catheters, right? You see these are deposits of calcium along the tubing because the um, barium on coated tubing, the barium leach out and causes an inflammation, you get thickening, right? And then this leads to fracture of the tube, tethering, and also tract fibrosis. And they account for about 2/3 of late failures needing revisions, right? So you can see here that because of this, they break, right? And actually, this problem actually has been described by this Christensen Rose and Spiros Sugaros actually in 1990. It's a long time. Basically, the thing is that you should actually avoid barium-coated tubings because it will lead to this. Ideally, if you should use this plain silicon with a strip of barium inside, right? And so these are much smoother and they do not uh, leach out, and then therefore you do not get the calcinosis and the type of catheter that we have mentioned earlier. Then when you look at valves, of course, there are many different types of valves, right? Yeah, most common are the fixed differential pressure valves, right? Then some of them have a anti-siphon device, some of them do not. Then of course, more and more we are getting the programmable valves, and then of course we also have programmable valves with anti-siphon device, right? Now, because most of the time we're using this pressure regulation, the fixed differential valve, the idea is to get to maintain a constant pressure, whatever the drainage flow, right? But in real life, actually, this is what you get, right? As the pressure goes up, the flow actually increase, okay? And the other thing to note is that if you don't have an anti-siphon device, then all fixed resistance valves suffers from siphoning. So basically, again, that will actually cause a problem, right? If you use just a fixed pressure valve. The other type of valves that we see is the flow regulated valve, and the one that's actually really easily available is the Aubrey Sigma valve, right? It's actually not so commonly used in our part of the world, but the idea is that you want to maintain a constant drainage flow rate for a large variation of pressure. But in real life, again, you get this type of curve, right? The thing is, actually, when you look at different valves, do valves actually make a difference? This is actually one of the results of the trial done in the US, I think in the 1990s, looking at the Sigma valve, the standard valve, and the Delta valve, which has anti-siphon device. And really, the difference is not, there's no difference. Whatever type of valve you have, your failure rate is still the same. So in those days, actually, the first year failure rate was actually close to almost 60%. Now, what about the use of programmable valves? What do programmable valves actually do? Okay, basically, the programmable valve, you can utilize a magnetic rotor to non-invasively set the valve opening pressure. So if you have initial pressure, what you're doing is that you're actually just increasing the pressure, right, as you change the setting, right? But you are still getting a flowing, the flow is such that the pressure goes up, flow goes, then pressure goes down, no flow, and so forth. And so this is what they call draining in spurts. And when you adjust the pressure, this is what you're doing. Right? So maybe the flow is less, takes a longer time, but it's just still, again, draining in spurts. So really there is a complex relationship in the brain between the tension and the volume of CSF that you get. Now, the brain obeys the same basic physical laws, although the mathematics is more complex because the brain is not a perfect sphere, the brain is not thin wall, but has very mental thickness, and is surrounded by an uneven skull surface, right? And then really, what are you trying to do when you put in the shunt? You're looking at biomechanical property of the brain, right? So are you looking at a high pressure in the low compliance system, or medium pressure in a normal compliance system, or low pressure in a high compliance system, right? So you have to ask yourself, what is my aim when I'm shunting, right? Right? You want to normalize, maintain ICP, you want to decompress ventricles, you want to avoid sleep ventricles. And actually, when you look at the brain, there are quite a few problems that you may see. So you have high compliance, you have non-compliance, you have low compliance, you have unknown compliance, and then in the NPH group, people susceptible to subdural hematomas and over drainage. So there are sort of shunts that you can use to actually decide whether you want for high compliance, you may have low resistance, low open pressure, normal compliance, which is most of the type of cases that we see, either low or medium resistance, medium opening pressure. But if there are low compliance, actually any resistance by high opening pressure. And then for unknown, you might then want to consider using a programmable valve and then or self-adjusting variable resistance valve. So these are ways of deciding what you want. But ultimately, though, in the real world, especially when it comes to children, and I say this only about children, not adults, any shunt can be used in any hydrocephalic state, and 80 to 90% will end up working. Why? Because in children, especially, most ventricular brain system adjusts to the shunt given. Right? So shunt failure is usually not due to ventral catheter occlusion, usually due to that, and not due to a mismatched valve. So really, any type of shunt you use in a child will do okay. Now, so that's all about shunts. Now we talk about third ventriculotomy. I think we all know what third ventriculotomy is. Basically, you use an endoscope to go down to the floor of the third ventricle and make a fenestration. All right. And the indications are is any form of hydrocephalus that's purely obstructive in nature with one or two sites of obstruction. So somewhere from the distal part of the third ventricle all the way to the fourth ventricle outlet and in front of this. Any form of obstruction there, third ventriculotomy can be used to treat the hydrocephalus, right? And I think we have seen from the work done by Ben Wav especially, and in Uganda, about being the treatment of choice. Uh, and even before Ben Wolf, and most of us were treating hydrocephalus, obstructive hydrocephalus using ETV and a success rate of more than 90%. And actually, one of the things that is very important is the ETV Success Goal put up by Kukani, which actually very accurately, I must say, gives you the idea of what is your success rate. And here, for instance, we know that children less than 6 months actually have poorer success rate because of, and so you can actually predict and use this graph score to actually work out what is the success rate uh, before considering ETV. Now, then what about ETV and CPC, correct plexus coagulation? So I think Benoit first reported technique of combining ETV with bilateral CPC to treat infants in about 2005, right? So when you must understand that in Uganda, he had a group of patients that are considered as post-infectious hydrocephalus. And in that group, 59% of them actually did well compared to 40% of the non-post-infectious hydrocephalus group, right? And then when he started doing CPC, he actually got better results, right? So was developed in the context of treating children for whom shunt dependence was more problematic and likely more dangerous than the case for those in developed country. So basically, when you had a CPC, you were looking at about 70%, right? And the rationale was that, right, ETV effective for obstructive hydrocephalus, right? You create the stoma and so forth. An infant with congenital obstructive hydrocephalus, right, probably have secondary delayed development of the normal CSF absorbable mechanisms compared to those with uh, post-infectious hydrocephalus who are more likely to have develop age-appropriate CSF powers prior to inciting infection. And this explains why ETV for infants is more successful for secondary aqueductal stenosis than for primary aqueductal stenosis. Right? And so you add CPC to increase the success rate of ETV and by reducing the rate of CSF production and decreasing the risk of treatment failure from inefficient CSF absorption. Of course, if you consider the pulsation theory, you can also say that actually ventricular dilatation requires driving force of the correct plexus pulsations. And when you do CPC, you actually burn off the correct plexus and therefore you reduce the self pulsation. And that in itself actually can also reduce the hydrocephalus. So two reasons why CPC seems to be much better. And but we must understand a lot of this actually was done. Work was done in Uganda, and even the ETV Success Score, they added a correct plexus cauterization to give points. Right, it means they add more weightage as an indicator of success. And then also there is a dose response effect, meaning that if you do partial CPC, you offer the patient some benefit compared to not offering CPC. And if you do a complete CPC, you're offering the patient even more benefit. Uh, So based on the work that he did in Ben Warfare and say that ETV plus CPC is effective for most etiologies of infant hydrocephalus, right? And includes melaminic and cephalocele, aqueductal stenosis, Danny Walker complex, post-infectious hydrocephalus, and congenital idiopathic complicating hydrocephalus, right? So the success rates are quite good. But we must realize that all this is in Uganda, right? When they did the same sort of trial in the US, and this is a paper that actually the results are actually not as good. It, right, so you can see that the CPC ETV does actually do a little bit better compared to just if there was predicted on the success score without CPC. All right, and predicted failures were post-infectious etiologies, treatment younger than 6 months, pre-pontine system scarring, and prior CSF diversion. So basically, it was less successful for post-meningitic hydrocephalus. You can see the post-meningitic hydrocephalus that they were treated, their success rate were very poor. So in the US, in the Western world, Right? Post-infection etiologies were noted to be a predictor of ETV plus CPC failure. Right? So possibly that's because the infection that you see in Uganda and the US are actually not different. Right? So this was a graph that shows also the age that in less than 6 months do worse than those that do better at 6 months. And interestingly, there's a recent article in this Science Foundation lesson. They actually have identified the bacteria that is the cause of the post-infectious hydrocephalus in Uganda, and it's called a Bacillus thiaminolyticus. Right? And so again, you don't see this organism in the our part of the world, right? So this was only seen in Uganda, and then some recent studies suggest that they've also seen this in Vietnam. So when you look at CSF shunting, right, compare and so this is not Ben Waswork. This is actually the other group of pediatric neurosurgeons. Right, you can see that actually the results of shunts actually are even better than CPC. Right. So basically, I think when you look at what sort of condition you have, right, whether it's a congenital, acquired, right, whether and then obstructive communicating, obviously the therapy is if it's obstructive, you remove obstruction, you want to consider ETV. But this is acquired, right? You can either do ETV, CPC, or actually do a shunt. And definitely in venous problems, actually you do a shunt. So that's all I have to say. And just like to remind you, hopefully things will happen. In November this year, we'll see you in Singapore for the ISBN meeting and the World Congress on Neuroendoscopy. Thank you very much.
Thank you very much, Professor Wang Tishu, for this elegant presentation and running through a very long problem. And I believe there are a few questions. Is there anyone who would like to ask any question?
Can I ask a question, Professor?
Yes, please go ahead.
Yeah, it's an excellent talk. You covered everything, Professor. You only one question. How about neonatal hydrocephalus? Now with most of the advanced antenatal imaging for pregnant mothers, many of these children who are to be born will be diagnosed with hydrocephalus even before birth. So, what do you suggest for them?
Neonatal hydrocephalus?
Yeah.
Sorry, antenatal hydrocephalus. That's right.
Antenatal and also immediately after birth.
I think
Immediately after birth. Yeah.
Okay, antenatal. I mean, we don't treat at all. I remember. I think Ahmad, were you treating with some shunts, antenatal shunts before? But I know you have stopped doing that. I think neonatal hydrocephalus. I think basically, you probably should just shunt because.
Or wait and watch or shunt.
Sorry.
You wait and watch for some time or immediately do some procedure.
I mean, normally we don't do it on day 1 or 2, but if the head is increasing, of course, we'll do MRI, make sure I try to identify the cause. But I think in most neonates less than 6 months of age, we probably will shunt. I've actually done a couple of ETVs in neonates 2-3 months old with aqueductal stenosis seen on MRI. I think the failure is like 50%, so, but I mean, I had one where the parent actually wanted it very much, and they were happy to wait. And somehow it seemed like the ventricle, the head was still getting bigger. But after a while, a couple of months more, it kind of settled down. So it's hard to predict. I mean, I think shunts are actually still very good. And I think in a neonatal aqueductal stenosis, I think you probably should shunt. And then the next time when you have a shunt failure, you actually just do a ETV.
Okay. What about cortical mantle thickness? Is it a criteria for you to decide whether to go ahead with shunt? Because when I studied neurosurgery, we were told that less than 1 centimeter cortical mantle thickness is don't shunt them. Is it still hold good or it is just old thought only?
I think it's old thought because I've actually had children with a very thin cortical mantle where we put a shunt, and then over years you scan them, you find that actually the cortical mantle actually has thickened. I think if it's just hydrocephalus pressure effect, you actually do get increase in the cortical surface. But if it's actually so the other thing is that some of the cases are ventriculomegaly, meaning they're ex vacuo, so actually brain tissue actually has been damaged. So those, the cortical mental would not, increase in size.
Thank you very much.
Yeah, I fully agree with you. This is, I think that was one of the most deceiving points. That's just to regard the cortical mental diameters in order to put a shunt or no. We have several patients, as you said, that is after shunting, few months later, the brain expanded and became normal. This is all due to the intracranial pressure and the diminished of extracellular space due to the pressure of intracranial pressure as a method of compensation. Professor Shu, I really liked very much what you said about not every ventricular dilatation is hydrocephalus. This is a very, very important point. The question comes when I get a patient, and especially for the young people, get a patient with ventricular dilatation and complaining of headache. What should I do? And know to shunt or not to shunt, ETV or not to be, is it hydrocephalus or not? How can you confirm?
I think this, you go down to clinical tests. So you look at is hydrocephalus, or not, and you look for papilledema. I mean, if really,
Yes.
If the fontanelle is already closed, you may not do. And I think in some of these cases where you really are not sure, I would actually do intracranial pressure monitoring. Yeah, because if they don't need a shunt, it's still better than putting in one and then having problems later on. I might tell the parents let's do a ICP monitoring and see. And if ICP is high, and then we just carry out the shunt. It's a two-procedure thing, but I think you may avoid having to put a shunt if it's not really due to raised intracranial pressure.
Absolutely agree, and this is really that is we could see a lot of around us that is this mistake of we say that is I can understand the dilemma which many of the young neurosurgeons may face when they have a patient with ventricular dilatation and the patient complaining of headache, and they really don't know what it is. As you said, the proper clinical examination is very important, and if there is a baseline CT scan, previous CT scan from anywhere, this would help to see the progress of the dilatation of the ventricles. And papilledema is an important sign. Continuous ICP monitor is very helpful. And if you have a TCD to measure, especially the optic diameter, is also very helpful to get it. Yes. But rushing, and even if all this confusing together, I prefer not to rush to put a shunt and just wait 3 months, repeat the CT scan again, and then you judge about it.
Thank you very much for all, Professor Raja, Professor Wan, and Dr. Ahmad, Professor Ahmad. My question, I have one patient nowadays. He is before 2 years. I make yesterday 2 shunts, but the hydrocaphalus is too much. EVD is benefit or to him or not? 2 shunts I make to him, Indian shunts. Very poorly, I make freely 2 shunts in the hydrocaphalus, too much. And ask Dr. Wan, please, Professor Wan. Thank you very much for you.
Okay. If you had to put 2 shunts, means that you are actually looking at a multiloculated hydrocephalus. I mean, one of those probably post-infection or post-hemorrhagic where you actually have, cysts and all that sort of thing form, and you might have to shunt. So those are the ones, I think it would be as simple as possible. To me, you're more than your 2 shunts or 3 shunts. It should be very, very complicated. And so more or less what we try to do is use an endoscope to fenestrate, so that basically we try to have the ventricular areas, 2 ventricles communicating, so that we can just put 1 shunt. I think it's not easy. I think the multilocated hydrocephalus, many times there are many issues. But I guess the thing is you try to simplify as much as you can. And I think endoscopy does work. And I've even had cases where I've actually had to open, just open surgery just to communicate multiple areas. Because sometimes even using the endoscope, you're just not doing enough to
One option, please. Can we make a low pressure shunt for this case? If you have again ATV for this patient, can we help him the exact 1 shunt low pressure?
I am not sure because I think I need to look at the scan, look at the patient. It's very hard to say exactly what is the best thing to do. I mean, usually in children, neonates, and we, especially when the fontanelle is open, I tend to put in a low pressure valve. But in an older child where the fontanelle is closed, I tend to put in a medium pressure. Right? And usually that is more than adequate, and you have little problem. So you when you put in the shunt at the end of surgery, you bless the shunt and you say, may you last for 30, 40 years, which unfortunately sometimes it doesn't happen. Yeah, but if you do, I think that very important as a surgeon is your surgical technique must be really good, and so that you don't have to keep operating on these children.
I think it was a great discussion. There are so many questions which I personally would want to like to Professor Montisio, but we'll come back after our honored second speaker who is waiting for us to give his precious lecture. May I please invite Professor Ahmad Umar.
Well, it is extremely pleasure to introduce my dear friend and Professor Lucas Rizoleschi. He's a person, a wonderful person. He's one of the people who really you respect and love from the first time you meet him. Generous man, intelligent man, very nice man. Plus, he is one of the world leader in peripheral nerve surgery. And he is really made his center as one of the center which everybody who would like to learn peripheral nerve surgery will go to him. We are looking forward to learn from your experience, Lucas.
Thank you, Ahmed, for this kind introduction. Distinguished colleagues of Asian Congress of Neurological Surgeons, dear chairmen and organizers, thank you for giving me opportunity to speak with you on this quite important webinar, education webinar. Congratulations for your all activities. Since you are very active in terms of organizing all these educational webinars, starting from the beginning of COVID-19 pandemic and lockdown. As my dear friend Ahmed introduced, my field of expertise is nerve restoration, nerve repair within neurosurgery. Just a short reminder that nerve repair, reconstructive surgery of peripheral nerves is an essential part of neurosurgery, as we all know, starting from our basic books from which we learned and from which new generations are learning now. So my title of my presentation is essentially related to the basic activities, from basic to innovative activities regarding peripheral neurosurgery in terms of implementing neurolysis, nerve grafting, nerve conduits, reimplantations in terms of lesions of peripheral nerves, which leads us to the nerve repair in 2021 and beyond. I don't have any disclosures. In some basic consideration from epidemiological point of view, you see that about 4.3% per 1,000 people suffer from some kind of injury of upper extremity which affects peripheral nerves. These are male individuals between the ages of 12 and 21 in, let's say, highest productive period of the life. Also, the other period from 30 to 60 is also a lot of people affected in terms of lesion of peripheral nerves. And this defect that brachial plexus injury may cause permanent disability of the previously healthy young people demands development on even better treatment plans and new surgical techniques for treatment of these patients. Not many studies are devoted to the evaluation of quality of life and patient satisfaction related to the recovery after following surgical repair of peripheral nerves, and there are some of the problems which can appear in, let's say, making difficult everyday life, starting from normal everyday life up to the professional everyday life and activities, which is a very essential part of our field. This is just a short announcement of the one very special book, which you can find very easily in a digital form, Earth 5.0 Provoke the Future, from my very close friend Karl Heinz Land, investigator of future, in which he describes a lot of new advances and technological advances and future perspective in terms of how life in the future will look like. And let's see if the field of peripheral neurosurgery is within these new advances, and where is the place of new achievements in this future. As you can see, this is highest precision of a man and highest precision of a machine. This is something what is very actual and ongoing in all fields of life, all fields of medicine, all fields of neurosurgery. And also, it is also active and ongoing in a field of peripheral neurosurgery. You will see in the future. So, is your art in your skill, and your skill is in your art, and no master is born perfect. This is a masterpiece in which you can see perfection. But it was not like that when it started to prepare. This is courtesy of my very close friend, Jacques Morcos. Just a comparative video how surgical skills appears in a mentor and mentee in making a bypass, vascular bypass. This is something very similar in nerve repair regarding demanding surgical skills, patience, and of course knowledge in repair of peripheral nerves. So peripheral nerve system surgery, traveling through no man's land to the new horizons, leads us to the new perspective in the future that nerve surgeon can be neurosurgeon, orthopedic surgeon, plastic surgeon, or microsurgeon, hand surgeon, who is continuously improve his education and subspecialization in terms of learning and improving skills in neurosurgeries. Now we have to distinguish replantation surgery, microsurgery, hand surgery from nerve surgery, from nerve repair, which is a secondary repair, and always come to the, let's say, end of the treatment of the patient. Just a short reminder of the sophisticated morphology and intraneural structure of the peripheral nerve. As you can see, this is a nerve and a connective tissue structure with nerve and connective tissue component. Both of them are extremely important to be in continuity for a normal functioning of the peripheral nerve, and regarding on which level we are making our repair of the nerve, knowledge of this morphology is of outstanding importance. Other thing which is also very important is intraneural systematization and organization of the nerves, including intraneural and extraneural vascularization of the nerves, which is very important to be preserved in preparation of the nerves. you see one nerve in its proximal and distal part can look like this. This is a proximal part of one nerve and distal part of the same nerve, or proximal part of the another nerve and distal part of the other nerve. This is a monofascicular, oligofascicular, and polyfascicular intraneural systematization of the nerves, which leads us to the question mark in a choice of surgical technique for repair the same nerve, but in a different level. And this is famous photo from National Geographic, famous cardiac surgeon Zbigniew Relija, following the vital signs after a heart transplantation, 23-hour long operation, and 22 years after Zbigniew Relija passed away, and his patient is still alive. This photo wants to imply to the importance of continuous following of our patients following the surgery, in which they have to be very active in physical therapy, and the results are appearing, let's say, approximately 9 months or 1 year after the surgery, because the regeneration is slow and hazard, and 1 millimeter for a day, regeneration of the axon. So surgical treatment strategy in decision-making process in nerve surgery are still matter of question between class 1 evidence based on preoperative evaluation decision or coin flip based decision making as a matter of intraoperative finding and surgical experience. Unfortunately, we have to say that there are very few criteria for class 1 evidence-based process in decision-making process for treatment of the nerves. Mostly there are class 2 or class 3 evidence-based studies, but international multicentric double-blind randomized cohort studies for improving the achievement of the class 1 evidence-based criteria for decision-making process are very important. So is the peripheral nerve surgery as important as clipping an aneurysm or resetting a brain tumor or spine stability or spine surgery? My answer is yes. So if we are talking about the interest in peripheral nerve surgery, I would like to present this as a crisis versus opportunity or challenge versus opportunity for young generation, to motivate them to start learn peripheral nerve surgery, because you will see in the end of this presentation, field of peripheral nerve surgery is still field where hand of the surgeon is a major impact factor. So we have a biological challenge versus opportunity. Nerves are regenerating. Repair is possible. But why results are not better? Results are not quite good always, because regeneration is slow, stopper, and hazard. And as I told you, 1 millimeter for a day. All nerve injuries are chronic, and regeneration is frequently misdirected, non-specific, and imprecise. Complexity of the nerve structure, such as brachial plexus, or as you can see, cervical plexus, is very well known. Having in mind all of this, there are still certain controversies in surgery of peripheral nerves. This, what we are talking about, are not controversies now. These are clear picture, clear indications for surgery. So open injuries with loss of the nerve continuity, closed or traction injuries, progressive neurological deficit due to the different conditions, such as growing of the pseudoaneurysm or compression of the nerve following different type of traumatic lesions, and causalgic and non-causalgic pain in conditions like following nerve lesions are absolute indications for surgery. So when we are talking about surgical repair of peripheral nerves, it can be divided as acute repair and or primary repair and secondary repair. Primary repair is acute exploration, possible repair within 24 up to 48 hours. So traumatic aneurysm or arteriovenous fistula, the presence of foreign body compartment syndrome, bone joint injury requiring internal fixation, and clear-cut lesions of the nerve are absolute indications for acute exploration. Open injuries as a timing of nerve repair, we are talking now, we have an ideal solution for these patients when we perform primary suture. This is in cases with sharp, clean cross-section of the nerves with no nerve deficit, no nerve defect, no gap of the nerves. In some circumstances, there can be a delayed primary suture. Primary suture is, let's say, 24 hours. Delayed primary suture is, some authors recommend 24 to 70 or for 72 hours. Early secondary suture and delayed secondary suture, this is something which is a question of debate between the experts in the field of peripheral neurosurgery, because early secondary suture can be recommended in open injuries. And delayed secondary suture is a matter of delayed admission of the patient in a center for nerve repair, for nerve reconstruction. Another category are closed injuries, and the timing of nerve repair is also a very important issue. So in a closed or traction injuries, timing of nerve repair can be, let's say, divided in 3 groups. 3 months without signs of recovery is something within 3 months of the following the injury without signs of recovery is what we call the ideal period for nerve repair. Exception of this situation are gunshot injuries and open fractures are treated as a closed injuries, and then the optimal period is 3 to 5 to 6 months following no recovery or non-atomic or non-equal or dissociative recovery of the nerves. And if neurological deficit appears after surgery, urgent reanimation is mandatory, of course. This is mainly in cases with iatrogenic nerve injuries. So we are talking about surgical procedures in a lesion with continuity. These are some controversies: external or internal neurolysis. Should we perform external or internal neurolysis in cases with lesion in continuity? So external neurolysis is mandatory. This is the compression and deliberation of the nerve. Internal neurolysis should be adjusted to the grade of intraneural scarring and should not result with isolated fascicles. Complications of the, let's say, overdoing of internal neurolysis is damage of intrafascicular connection and damage of intraneural vascularization and recurrence of the fibrosis, intraneural fibrosis. So this is some illustration of the nerve lesions in continuity, nerve dissection, starting from the healthy part of the nerve, external neurolysis, removing nerve adventitia, and sometimes epifascicular epineurium, but remove the perineurium. And these are some examples of the external neurolysis of the left peroneal nerve following injury. This is clear, simple decompression, deliberation, and external neurolysis. When we are talking about nerve lesion in continuity and internal neurolysis, we can discuss about epifascicular epineurotomy, epifascicular epineurectomy, and interfascicular epineurectomy. This is depending on level of intraneural fibrosis, and of course, usage of intraoperative electrophysiological monitoring is mandatory. These are some examples, illustrative examples, how it can look like in different type of fibrosis. Then internal neurolysis in, for example, lesion of the median nerve caused by scar tissue. You can see excellent recovery following internal neurolysis, interfascicular neurolysis of median nerve. And this is maybe most famous and most let's say, efficient example of neurolysis of the radial nerve, because radial nerve associated with humeral shaft fracture is lesion of the radial nerve is the most frequent lesion of the nerve in continuity, in which after following surgical repair in terms of neurolysis, recovery is excellent. So when we have a lesion without continuity, we have two possibilities. One is direct suture, another is reconstruction of the nerve deficit, nerve gap. So if we don't have nerve deficit, nerve gap, direct suture is an ideal method. It can usually it's doing in acute phase, and later phase. Usually we use nerve gap reduction procedures. So this is a nerve lesion with a clear transection. We have a stump preparation, approximation, cooptation, and maintaining the cooptation. And this is some examples of stump cooptation in terms of epineural repair, group fascicular repair, or fascicle to fascicle, or fascicle reparation repair. So maintaining the stump cooptation, later on you will see in one slide when the question is controversy is should we use only microsurgical suture, should we use only fibrin glue, or should we use combination of microsurgical suture, which can be epineural, epineurial, interfascicular, epiperoneal, and of course guiding sutures, or combination of these. And there are some non-suture techniques such as fibrin glue, silicone tubes, and laser technique in terms of assisting of maintaining the stump cooptation. So factors that affect gap distance are defect to the nerve tissue due to the injury, defect to the nerve tissue due to the stump preparation, elastic retraction of the stumps, fibrous retraction of the stumps, and joint position. Additional procedures for reducing the gap distance between nerve stumps can be mobilization of the stumps, transposition of the stumps, and alleviate of joint position. So this is direct suturing. And this is, as I said, ideal method. And now we are going to the situation with lesion with without continuity, when we have a nerve gap, nerve defect, deficit. And this technique we never use primarily. Nerve gap should be longer than 2 centimeters. Let's say 1 or 1.5 centimeters can be adapted by these techniques that I mentioned before. And the disadvantages of nerve graftings are 2 suture lines, difficult identification of appropriate fascicle, the difference in fascicular structure of the branch and the graft, and fibrosis of the distal suture line or long grafts. And the results of direct suture are better even in relation to those using short grafts. And this is how it looks like when we are preparing different types of nerve grafting, such as single fascicular grafting, cable grafting, modifying cable grafting, and usually we use for graft autograft or allograft, which is usually sural nerve, as it is very well known, although other sensitive nerves can be used in these circumstances. So in nerve grafting, we can use neural transplantation as a free grafts or vascularized grafts, and the non-neural tubes, which can be synthetic, vein and muscle. So vein and muscle tubes are nowadays no longer used. So these are some advantages of interfascicular nerve grafting, such as precise adaptation of nerve diameter, better fascicular orientation, better blood supply, graft revascularization, and reducing fibrous reaction. These are methods for cooptation in nerve grafting: stump to graft, sector to graft, fascicle to fascicle, fascicle to more grafts, fascicle to one graft, fascicle to fascicle, or the fascicle transplantation. Non-vascularized nerve grafts versus vascularized nerve grafts. In majority cases, we are using non-vascularized nerve grafts. Vascularized nerve grafts are used only for nerve repair in the ischemic zone, in long proximal defects and wide nerve grafts. Cable grafting is an important modification of the grafting procedure, and indication for cable graft are polyfascicular nerves with diffuse distribution, combined oligofascicular and groove fascicular distribution, and limited mobility of the stumps, with some disadvantages of this grafting. But simply to simplify all this story, same nerve proximally we repair with cable grafting because it's polyfascicular intraneural distribution, and the same nerve distally we repair with interfascicular nerve grafting because of the oligofascicular intraneural systematization. And this is some intraneural intraoperational photos under the microscope. These are identifications of the fascicles. As you can see, coaptation of the sural graft and the fascicular group, approximation, and this is coaptation. And then we have 2 microsurgical sutures for maintaining the suture line, 2 sural grafts to the 1 fascicle groups in terms of completion the suture line due to the difference of the diameters. And this is 1 interfascicular nerve graft. And this is an example of the this modified cable grafting, in which we use fibrin glue to make artificial epineurium to, let's say, make it easier suturing with the grafts. And this is how it looks schematically. And this is how it looks like intraoperatively. And this is modified cable grafting of the peroneal component of the sciatic nerve and the partial split repair of the tibial component of the sciatic nerve with cable grafting. And this is cable grafting of the left ulnar and median nerve injury. This is, you can see the lesion of the ulnar and median nerve, how it looks like preoperatively. And this is also peroneal nerve. So factors that are influencing treatment outcome of the peripheral nerve injuries are age of the patient, type of the nerve, injury characteristics, which we mentioned already, excluding length of nerve defect, length of nerve gap, which is, for example, up to 5 centimeters gap which is repaired with nerve grafting gives excellent results. 5 to 8 centimeters results are also good, and up more than 8 centimeters nerve gap results are in some circumstances controversial. So surgery and post-operative rehabilitations are also major impact factors in this situation. So nerve grafting or tubes and conduits. The reason for using tubes are complications related to the donor nerves and small nerve gaps, small nerve defects, and small caliber of the nerves. So indications for tubes repair are mostly digital nerve injuries and the nerve gap between 1 and 3 centimeters and the diameter of the stumps up to 10 millimeters. These are some of the artificial nerve repair solution and the portfolio with nerve connectors, nerve protectors, and this is also in everyday practice, but this is also not so cheap. And the results are, let's say, good in these conditions which I mentioned. But another controversy is suture or non-suture anastomosis technique. So I mentioned the microsurgical suture. Usually we use 10-0 or fibrin glue. Isolately only suturing, isolately only fibrin glue, or both. So in our opinion, ideal solution is a combination of both techniques in terms of, let's say, completion of the suture line. I will now just make a review of nerve transfer techniques in brachial plexus reconstructive surgery. The nerve transfer is technique which leads us to the reinnervation of the functional priorities of the brachial plexus with usage of some other nerves, sacrificing the function of that muscle, which is less important for that patient in that moment. And nerve transfers appears to be a very efficient procedure and very effective procedures, which improve the quality of life and quality of recovery of the patient in these cases. So nerve transfer has advantages, which are direct suture, anastomosis close to the target muscle, shorter regeneration span, bigger number of regenerating axons, repair outside of the injury of scar zone, faster and better innervation. And indication for nerve transfers are root avulsion, proximal intraforaminal injury, extensive longitudinal nerve gaps, significant vascular and bone injuries, extensive scar tissue, delayed surgery for after 12 months, and previously unsuccessful direct nerve repair. So some examples: nerve transfer, one of the most, let's say, popular nerve transfer with efficiency of 50% is intercostal nerves, 2 or 3 intercostal nerves, mostly third or fourth to fifth intercostal nerve to the musculocutaneous nerve in total brachial plexus palsy cases. Another solution for elbow flexion, then spinal accessory to the suprascapular nerve via anterior approach. Also in these cases for arm abduction in cases with total brachial plexus palsy. This is in complex cases situation with a long nerve grafting from viable proximal C5 stump and loss of other stump C6 to C8. So direct grafting with a long nerve grafts to the functional priorities, musculocutaneous and axillary nerve for these cases. This is also one of the interesting modification of the nerve transfer, such as usage of the regional nerves, thoracodorsal nerve and pectoral medial nerve to reinnervate the musculocutaneous and axillary nerve. These are the cases, C5, C6 cases, with preserved C7 because of the intraneural systematization of the brachial plexus. Also, another solution with posterior approach for innervation of the axillary nerve with preserved C7 in cases C5, C6, with usage of branch for radial nerve for medial head to reinnervate of the triceps muscle to reinnervate the axillary nerve. This is the most famous and most efficient transfer procedure for achieve the elbow flexion to reinnervation to the musculocutaneous nerve or branch for biceps. Identification of the fascicular group for from ulnar nerve and direct transposition to the branch for biceps in terms for reinnervation of the musculocutaneous nerve. These are modifications and combinations of the nerve transfers, such as double fascicular nerve transfer for the same purposes. This is a complete SOMSAC procedure, which is consisted from innervation of the axillary nerve via branch of the triceps nerve and the axillary nerve to the suprascapular nerve via posterior approach. And this is how it looks like in this video suturing. I will now just fasten this to see how it looks like in these circumstances. This is, of course, under the microscope. So this is direct cooptation without tension of the suture line to the branch of the radial nerve for medial head of the triceps to the axillary nerve and the completion of the suture line. including perineural tissue. So in terms to be faster, what we are facing now with robotic surgery, artificial intelligence. And this is endoscopic exploration and repair of the brachial plexus with telerobotic manipulation using Da Vinci robotic surgery system from Brazilian group. This is a cadaver trial, and you can see how it looks like in a cadaver. Identification of all elements of the brachial plexus. Including performing nerve grafting from C5 and C6 to the trunks. Also, Brazilian group are very, very, let's say, innovative in using these new techniques. So they perform quite a few cases with opening procedure with Da Vinci robot, 4 cases, and the SOMSAC procedure via Da Vinci robot, 6 cases. And they achieve a quite satisfactory outcome 1 year after surgery. So opening procedure gives excellent results, like in, let's say, open classic surgery, and in the SOMSAC procedures, they receive also nice results regarding abduction up to 112 degrees. There are still some current limitations in surgical robotics in everyday practice, especially in the field of peripheral nerve surgery, but this is implementing mandatory. And one of the also important issues in peripheral nerve surgery is nervous system, central nervous system reorganization following injury. So cutting your nerve changes your brain. And this is evident or evidence-based. And the brain has one special characteristic, which is plasticity. And neuroplasticity is especially activated in this field, particularly after brachial plexus injuries and following nerve repair. This is something, as you can see, with functional MRI changes in activating nerve plasticity following intercostal nerve transfer to the musculocutaneous nerve transfer for reconstruction of the brachial plexus injuries to, let's say, divide the inspiratory respiratory function of the elbow flexion, and then also sensory motor cortical changes for other cases with brachial plexus injuries. And this is a model of 7 brachial plexus injuries with remodeling of the functional priorities in the brain and uptaking the functional changes with the other parts of the brain. Another situation is phantom limb pain when we have a case of maladaptive plasticity. Patients with leg amputation with phantom pain. These are changes in the brain. So in future perspectives, we can expect further development of cell therapy, stem cells, Schwann cells. Usage of Schwann cells is function in stimulating potential to make a potentiation of the nerve regeneration as either response to nerve injury, either combination with stem cells or transplantation with olfactory and shitting cells for peripheral nerve regeneration. Stem cells are now, let's say, practically in stage 1 of usage. Then gene therapy for peripheral nerve repair is also now developing. For adjuvanting nerve regeneration, also phototherapy. And one of the most important issues is augmenting neurodegeneration with electrical stimulation. Pharmacological agents for neurodegeneration are between diet, nutrition, and supplementation of the let's say helping a neurodegeneration in some matter, but not in some let's say important issues. And then in most difficult cases which require amputation after non-successful reconstruction of the nerves and amputation of the limb, especially following the erosion of the roots in brachial plexus cases, we can also discuss about the bionic hand for elective amputation patients, but this is also open issue. Is its outcome after peripheral nerve repair, is it perspective or not? And these are most difficult cases such as modular prosthetic limbs, which can also be included in everyday practice. Artificial intelligence is improving. We are now facing with interfaces for every part of preoperative, intraoperative, and postoperative evaluation in peripheral nerve surgery, but education and transdisciplinarity in our cases is of outstanding importance. And these are some of the events when we promote peripheral nerve surgery worldwide, so far live, now online via Zoom, but these are World Federation of Neurosurgical Societies Committee for Peripheral Nerve Surgery hands-on courses, and this is our goal: functional recovery for following lesion of the peripheral nerve after surgical repair. And in conclusion, there are still some limitations of nerve repair. We cannot be quite satisfied for the recovery if the patient himself is not, especially when we are talking about non-functional hand. Some perspectives of nerve injuries, of nerve repair, are more efficient surgical techniques, improving of surgical techniques, and future development of new concepts, such as cellular surgery concept, pharmacological activation of regeneration, nerve elongation, non-neural tubes, and non-suture techniques of nerve anastomosis. Still, reconstructive surgery of peripheral nerve system is difficult and challenging, and class 1 evidence-based strategies are still matter of further double-blind, randomized, multi-center controlled studies. Surgeon decision based on a knowledge and experience is still predominant input factor, and hand of the surgeon are or is irreplaceable factor, despite how world would like in 21st century. So keep calm and raise awareness and love brachial plexus surgery. This is my teacher and mentor, Professor Miroslav Samaric, and my family. And this is some invitation with real, I do hope real possibility to continue with our live activities at the second part of this year in Belgrade, an annual meeting of Serbian Neurosurgical Society with international participation. We postponed this meeting last year, and our major event, which should happen last year in October, but also postponed due to the COVID-19, and we moved the Congress in 2022. So we really do hope, I really do hope that we will meet very soon all together live to continue our activities. Thank you very much for your attention.
Thank you, Lekas, very much. It's wonderful lecture, and really you discussed a very important subject, and you ran through many issues. I believe there are several questions, and now the floor is open for any questions.
Yeah, I think there will be many questions. First of all, I would like to invite our co-host, Dr. Liu Bun Singh.
Thank you, Raja. Thank you, Professor Lucas. Nice meeting you again, Prof. I wish to ask Professor regarding nerve transfer. Do you have some form of physiotherapy, so-called, to teach the brain to move the limb with now the nerve is serving the other different muscle? Second question, I would like to find out from you, Prof. Nowadays, we use, they found out that the exoskeleton is useful in the treatment of stroke, in terms of stroke recovery. Do you find that those exoskeleton is useful in the peripheral nerve recovery? My last question for you, Prof, is how do you assess success of your surgery? Either just through a clinical assessment or some form of imaging, for example, an MRI, and what are the sequences that you prefer to look at the success of your surgery or the nerve recovery? Thank you, Professor.
Can we start from the back? I mean, I will answer you from your third question. So we assessed the quality of recovery with clinical scales, functional scales, and EMG evaluation, ultrasound, and in some cases, when we are, let's say, investigating nerve regeneration, we are doing MRI neurography. This is let's say, how we do it usually, how we assess this patient in regular practice. Regarding exoskeleton is very useful thing. I believe that it can be very helpful in recovery of the patient in physical therapy. And first question was, once again,
nerve transfer.
Yes, regarding generally, or it's particular one.
How is there any specific so-called therapy that been introduced to teach a nerve to move certain muscle after the nerve transfer procedure?
To introduce some particular nerve transfer for reinnervation of the musculocutaneous nerve. Is that the question?
Yes, Professor.
So the Oberlin procedure is let's say in 98% effective with M3 up to M5, M4 to M5 recovery of the musculocutaneous nerve. So Oberlin procedure is extremely successful. So this is a Oberlin procedure, which means nerve transfer of the fascicle of the ulnar nerve to the direct nerve transfer to the branch for the biceps muscle of the musculocutaneous nerve, which means that you have to make a dissection of the musculocutaneous nerve distally from coracobrachial fascia, and to identify branches from biceps and from brachial muscle, and then to make direct innervation of the fascicular group for extensor for flexor carpi ulnaris directly to the branch for biceps to achieve excellent elbow flexion. This is a top quality elbow transfer. Also, combined SOMSAC procedure with posterior approach with spinal accessory to the suprascapular nerve and innervation of the axillary nerve with preserved branch for medial head of triceps nerve. This is for C5, C6 lesion is combination with Oberlin procedure, almost 100% excellent recovery. Of course, no matter the most important factor is timing.
Thank you, Professor.
Thank you so much, Professor Lucas Rasulis. That was very interesting and beautiful presentation. The questions are open to both the speakers. One question I would like to ask Professor Vantishu. Professor, what is your policy in regard to the protein content of the CSF and insertion of the shunt? Is there any cutoff value above which you do not consider inserting a VP shunt?
Okay, so I think if the proteins are very high, actually, I don't have any specific number in mind. I mean, actually, when you look at the valve technology, they actually can withstand protein very, very well. You know, I think the valves get blocked up is by blood and all that, but actually proteins in themselves are not really would affect valve function. But I guess if the proteins are very high, you might want to just wait a while. But there have been situations I've seen where somehow for some reason the proteins never really go down, and you might want to, in those cases, you might still have to shunt because of the EVD might not be, you might either have to keep changing and putting a patient on EVD or something before you actually do a shunt. So in some situations, if the proteins are a bit high but not that bad, I would still shunt the patient. I mean, even the say CSF, like say post-hemorrhagic cases, sometimes the CSF is still quite fairly brownish in color, old blood. Usually those are not a big issue, but I think fresh blood is a big problem for shunt. So you shouldn't be shunting when there's fresh bleeding or just recent fresh bleeding.
Thank you for the answer. But there is, in line to that, I would like to ask, what is the alternative in those scenarios? Can you suggest any other alternatives? And especially in these scenarios where the patients are neonates with post-infectious hydrocephalus with high protein.
I think in India, the neonates, they are using a lot of subgaleal shunts. And actually, Sandeep Chatterjee reports very good outcomes. In many of them, they actually become shunt free. So actually, you open up you connect the tube from the ventricle to the subgaleal space. You extend your subgaleal space a little bit bigger, and then the fluid goes there, collects there. You can actually take a needle and aspirate some of that if the swelling gets too big, and then over time, the amount of blood and protein actually settles down. Right? I mean, we don't do it in Singapore. Usually, if we necessary, we actually put an EVD instead. But I mean, a subgaleal shunt is actually a very good alternative in that sort of situation.
Yeah, we have used the subgaleal shunt very often. In fact, I published my article in 2018 regarding the outcome of ventricular subgaleal shunt in infectious and non-infectious hydrocephalus. And the there was a conversion rate to VP shunt in 55% in infectious and 87% in non-infectious hydrocephalus. And we did the conversion after the neonates had achieved good weight, and that was our, but the mortality was higher in infectious etiology of hydrocephalus. If you ask me how good it is, I would say if it works well.
Yes.
That is the only answer I can. If it doesn't work, it doesn't work at all. So we are really looking forward to find an alternative to this neonatal meningitis baby with hydrocephalus. Yes, Professor Suresh.
Let's say my question is a continuation of that protein content. How about the number of cells? I know that any neutrophils in the CSF is contraindicated for putting a shunt. But how about tuberculous meningitis? What in India, many a time, up to 50 lymphocytes are allowed. Is it correct, Professor Van Q?
I think you are the expert in TB meningitis, not me, because we don't see a lot of TB meningitis in our part of the world. And I know that actually in many of these cases, you actually don't want to shunt because the large ventricles there are actually a sign of brain softening rather than actual ventricular raised intracranial pressure, if I'm not mistaken. So yeah, I know you guys know more about TB meningitis than I do.
Not exactly, much better than all of us. So what, in bacterial meningitis, normally any neutrophil there means in the cell means
yes,
they are
probably
contraindicated.
possibly of some infection. I think neutrophils, you get more than say 10 or
lymphocytes
whatever.
up to 2 lymphocytes in bacterial meningitis, and
I think
up to
lymphocytes are okay because lymphocytes are more the reactive thing. But I think, neutrophils are something you will be concerned about because there might be still ongoing infection. That's why I mentioned that, even when you reshunt after an infection, that's really something that different people have different ideas. Do you get 2 negative, 3 negative cultures? And then, of course, as you mentioned, what's the amount of protein inside? What's the amount of white cells? So these are issues that I don't think there's a clear answer, because sometimes if a patient has been on the say an external ventricular drain for more than 10 days, I mean, You want to keep patients.
Absolutely, you're absolutely correct. Yeah.
There is one question which has popped up on the chat box from Dr. Rajesh T. He wants to ask the indication of low pressure shunt or the change in decision making for shunt type based on open or closed anterior fontanelle.
So traditionally, I've been trained that if you have a newborn, open fontanelle, that means that actually pressure inside is low. If you need to shunt, you use a low pressure valve. And then as the child gets older, the fontanelles have closed. You probably use a medium. I mean, this is in the days when you don't have precision valves. You have because you know that the type of valves you use, what is low cannot be low because it's a range, because it's made of silicon. So it's not a precision. The metal ones, the precision ones, yes, you can actually set the pressure. But the type of valves that we use, because they're made of silicon, when they say low pressure, they usually is a range, maybe something between 3 to 2 centimeters to of water, or 2 millimeters of mercury to say 5. But then a medium pressure could be 4 to 8, high pressure could be 6. So actually, what is medium to some and what is high could be also very different because they're not precise. The other thing is also, do you use a slit valve at the end? Because if you use a slit valve, then actually what you have is actually a resistance in series. And so actually you're using a higher pressure shunt than what's actually on the valve itself. So I think these are considerations, but like I say, the luckily for many of us, it does not make that much of a difference because the brain in a child does adapt to the type of shunt you put in. So the majority of children, you will not get problem regardless of this, the type of shunt. I think the issues arise when you actually have a very low compliance type of, let's say in a child, open fontanelle, huge ventricles. I mean, these are the ones that you got to be careful because you put a low pressure in, you could actually cause also subdural collections, over drainage, and even long term, you get sleep ventricular syndrome.
Just a comment and then go to Lucas. Yes, I agree that his protein now is not a big problem for the shunt. But there are a trial we are doing now after in neonates, especially after infection, and the protein or without infection, if the protein is high, we try before inserting the shunt to wash the ventricles several times gently. If there's infection, even we do sometimes interesting. I haven't got the final results yet, but my very, very first impression, it does help for the patient really to have maybe the shunt will survive without obstruction. It is very gentle irrigations with saline. It's normal saline if there is no infections, but for the patient with infections with saline. But before that, we have to do, especially with infected cases, I would prefer to do MRI with contrast. That's to be sure there is no early loculation of the ventricles and where to put a shunt. So this is just a comment. But I would like to go to Lucas because he provoked a lot of important questions, especially about transfuture anastomosis. I would like to know your experience. Now it is gaining, actually, use the bioglue and use CO2 laser for end-to-end anastomosis. How do you really, from experience, how these methods are effective? It's not only in the short run, but on the long run. And how are you satisfied with this?
I have seen several experts in the field that they are doing completion of the suture line, especially when there is ideal cooptation without tension of the suture line, only with the fibrin glue.
Yeah. Yeah.
And the explanation for this is avoiding to provoke additional fibrosis on the suture line with microsurgical sutures, which makes sense. But I prefer to make it combination, to do 2 or 3, let's say, situation suture for a stabilization of the suture line, and then to put fibrin glue. And this is something which it appears that is quite efficient for stabilization of the suture line.
I really love to see a study, randomized study, see which method is better and when is indicated and when is not indicated. And this because I don't find, because really we started to see people, we tried fibrin glue. Personally, I am not very happy with it, but it is personal impression. But we would like really to see study about that.
So study about this might be to visualize a suture line following surgery with some additional imaging procedures, imaging methods. On the first place, if the suture is still on the place, if the suture line is still on the place, is the fibrin glue enough to keep the stability of the suture line? And another thing is to let's say to visualize regeneration through the suture line with some method. These studies can be done in some centers which are, let's say, highly sophisticated and with new achievement or new technological achievement and 7 Tesla MRI or something like that in terms of visualization of regeneration through this end of suture line. And this is very difficult to have a, let's say, randomized study in terms of comparing, let's say, only fibrin glue, only suture, or a combination of those techniques. And
yes.
Not to mention that you have ethical problem because you have to leave the series, you have to make a series of patients, for example, I don't know, 20, 30 patients with only fibrin glue, and then with same number of patients with only microsurgical suturing, and then some same number of the patients with the combination of these two procedures. Very, very complex, I would say.
Yeah. Yeah, and thank you very much for mentioning the ethics of this, because this is really serious ethical question.
Yeah.
You know, to offer a patient something is not really tried carefully. Yeah, and just build, you know, based on advertisement, but still there is no real strong study about it, especially in the long term.
Yes,
but that is very, very important issue.
Vast majority of experts in the field they agreed that it's ideal to, and then you have a most, let's say, most likely, most efficiency.
Yeah.
Yeah. Thank you so much. I think it's I would like to go back to our chair for his concluding remarks before we wind this up officially.
Well, thank you very much for everyone attending this wonderful webinar. I think all of us have been benefit and learned something from the two outstanding speakers. First, we want to, Professor Wanti Shu talked about the hydrocephalus, the classifications, the different types of hydrocephalus, and also the different technique for surgery and for management from shunt to endoscope and the complication and the shortcomings and benefit of each one of them. And really the most important part for me, he emphasized about that it is all, that is most of the valves are more or less the same, but which matters is the technique and the technology, which really makes a big difference for the shunt. And also from the discussion about this, about the low pressure and the high pressure and the medium pressure, I think that is still a big question about what is the normal pressure of the normal intracranial pressure for neonates. And is it the same? Is it one value or is it different values? Is it the same with anterior fontanelle or not? A large, anyhow. But also he mentioned, Dr. Schut mentioned an intelligent point, not every ventricular dilatation is a hydrocephalus. And we should really know the case, diagnose it probably before we put a shunt or start the treatment. This is regarding the first, regarding the first presentation. The second elegant presentation Lucas went through, I think, all the curriculum of peripheral nerves, from the different type of injury, different type of anastomosis, different type of transportation, different types of technique for repairing, and also he extended his experience about which is good and which is better about the direct anastomosis and internal and external neurolysis, and which is really important issue because of the car accident or any accident, especially for the radial nerve. And this is important issue for that. And also he went not only about the different techniques, he was told about the research and the other non-suture methods, which has really started to gain popularity nowadays in different places of the world. But there is different, we have to take it with precaution because that is a basic home workup, research workup is really not done yet. And then also he went about the future of hydrocephalus, future of peripheral nerve, which is really great, about robotic, about stem cells, about Schwann cells, about gene therapy, about phototherapy, about all of this important issue, which really will opening a door for a future of peripheral nerves. So really, I enjoyed very much, and I learned it from both lecture. And thanks a lot for the both speakers. You give us excellent information, and wish to see you face to face in not very far future. Thanks to everyone for the questions, and would like to thank as well Raji and his group for this organizing such wonderful and maintaining this series of webinars, which is very important for everyone. Thank you for everyone.
Thank you so much. Unfortunately, due to lack of time, we not take any further questions. So I'll close this officially on behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato. I would like to sincerely thank both the speakers for today, Professor Valentishu and Professor Lucas Rasulich, as well as the chair, Professor Ahmad Umar, who came us and taught us very elegantly about the respective subspecialties. We learned a lot today. Thank you so much. Thank you all the distinguished faculty who joined, Professor Suresh Nair. Special mention of word of thanks to Professor Shubin and his colleagues for translating this webinar lectures into Chinese and broadcasting it on the WeChat channel. Today we had 1,250 neurosurgeons around the world who watched this live. Thank you, Dr. Liu Bun Singh, for being my co-host today. So until we meet on next Saturday, it is bye-bye from all of us. Thank you all for joining.